Good evening to everyone. I welcome you all to ISA Online PG classes. These classes are held on every Monday, and today with us we have our esteemed faculty, Dr. Sangeeta Khanna, to discuss about one lung ventilation. I welcome you, ma'am. So ma'am is a senior director in Vedanta Institute of Critical Care and Anesthesiology, and her areas of interest includes transplant surgery and thoracic surgery. She has more than 40 publications and many chapters. She is keenly involved in DNB program of the institute. She is past president of ISA Haryana and has been awarded from fellowship from Indian College of Anesthesiologists. I welcome you, ma'am. To chair the session, we have Dr. Jayashree Sood. Madam needs no introduction. She's a chairperson of Institute of Anesthesiology, Pain and Perioperative Medicine and Secretary, Board of Management and member, Board of Trustees, Sir Ganganam Hospital, New Delhi. Her achievements include member of Specialist Board in Anesthesia of National Board of Examination, founder, member, trustee and president of ICA. She is honored by IMA Medico Healthcare Excellence Award in 2019 in Excellence in Anesthesia Management at Hyderabad, Atal Swasthya Bhushan Samman 2019, Teacher Par Excellence Award 2020, Best Teacher Award 2018, and Best Academician Award from Sir Ganganam Hospital. Women's Day Award, Women Can Do It All, Choosing an Unconventional Career Path Driven by Passion, by Global Time 2022 at Delhi. She's a DNB examiner and examiner for MD and DA in several universities. She's a member of editorial board of many national and international journals. Madam has received numerous orations, Dr. Venkat Rao oration, Professor S.K. Shah oration, Professor V. Rajgopalan and Professor V.J. Appukutti Memorial Oration, Dr. G.L. Kamra oration, Dr. V.A. Punoz oration, Dr. B.R. Mittal Memorial Oration, Dr. A.M. Deshpande oration, Dr. B.V.R. Shastri oration, Prankit 2019 oration, Dr. Deepak Malviya oration, Dr. Piyush Malik oration, and recently AOA oration in Chandigarh. Her publications include 141 publications in national and international journals, and she has 30 chapters in various books. She is editor of books Anesthesia in Laparoscopic Surgery, Volume 1 and 2, Anesthesia for Transplant Surgery, Clinical Thoracic Anesthesia, COVID-19 Pandemic and the Anesthesiologist. She is author of Atlas, Procedures in Neonate and Pediatric Practice. Her areas of interest include anesthesia for transplant, thoracic, laparoscopic surgeries, and pain management. I welcome you, ma'am. So we'll begin the session. During the course of lecture, all the participants will be muted. And if there are any queries, you can type your queries in the chat box. The queries will be taken at the end of the lecture and all the participants will be unmuted. With this, I request Dr. Sangeeta to please start the session.
Thank you, Monica, for that generous introduction. So good evening, ma'am, and all the respected seniors and our delegates who are present today. So today I will be speaking on one lung ventilation, and just to clarify, one lung ventilation is not synonymous with thoracic anesthesia. That is what we should all understand. One lung ventilation is a part of the strategy which may be used in thoracic anesthesia. It could be a part of cardiac anesthesia. It could also be in GI surgeries for esophagectomy patients or your spine surgeries in neuro patients. Also in the critical care and the ICU when you have a patient who comes with trauma, with disruption of the tracheobronchial tree, or a patient who has a ruptured cyst and there's an abscess and you want to isolate both the lungs. So hence we should not just think of one lung ventilation as a part of thoracic anesthesia, but something that all of us should know because we don't know when we may need it. So to talk about it, I have divided my talk into two parts. The first part, I shall be discussing the isolation, that is lung isolation techniques that we have and the measures that are used. And in the second part, I shall talk about the strategies which are required for one lung ventilation. So what is one lung ventilation? One lung ventilation means separation of the two lungs, where each lung functions independently by preparation of the airway. What does it provide? It provides protection of the healthy lung from the infected or bleeding one, causes diversion of ventilation away from the damaged airway or lung, and also improves exposure in the surgical field. But what does it do? It causes more manipulation of the airway and hence more damage. There is significant physiological change and hence easy development of hypoxemia. What are the indications? The indications for one lung ventilation, as I described, could be isolation of one lung from the other to avoid spillage or contamination. For example, if you have a lung abscess or a hydatid cyst, or you have an infected cyst which has ruptured. It could also be for control of disruption of ventilation. For example, if you have a bronchopleural fistula or a tracheobronchial tree disruption, and for unilateral bronchopulmonary lavage, for example, in patients with alveolar proteinosis. The relative indications include surgical exposure or in patients with post-cardiopulmonary bypass status after removal of a totally occluding chronic unilateral pulmonary emboli. So what are the options available for us to achieve this lung isolation? We know that there are three main techniques which are available for us, or devices that we have. First is the double lumen tube, which is the gold standard. The second are bronchial blockers, and third is the endobronchial tubes. We shall discuss each of them in detail one by one. First, let's see what a double lumen tube is. As we all know, a double lumen tube consists of two lumen. One it is a tracheal lumen, the other is the bronchial lumen. The bronchial lumen is the blue colored lumen, as we can see. This is the blue colored cuff. And to inflate it, there is a pilot balloon, which is blue, again blue in color. And we have the tracheal lumen, which has a white colored tracheal cuff and a tracheal pilot balloon to inflate it, which is again white color. This is color coded so that it is easy for us to identify which is the bronchial cuff and which is the tracheal cuff. In order to know which side tube, there is a difference in the design of both the left and the right sided tube. We need to understand a bit of the tracheobronchial anatomy. As we see, the width of the trachea is around 18 to 19 millimeters. But when we look at the division between the right and the left, we can see that the right bronchus is more wider as compared to the left bronchus, whereas the left bronchus is much longer as compared to the right bronchus. The other important thing which we need to know is the uptake or the outshoot of the right upper lobe, which we have to ventilate, especially when we are using a right-sided double lumen tube. And because of this, we see that there is a difference in the structure or the design of both these tubes. If we have a closer look, we can see the right-sided tube, it is a much oblique. This is an oblique shaped bronchial balloon that we have, and the length is much shorter. And also there is a slot which is there to ventilate the right upper lobe. Whereas when we look at the left-sided double lumen tube, we can see that it is much longer and it is a more smaller and a rounder cuff that we have. And this is because of the difference in the design of the bronchus on the right and the left side. How do we decide what length and what size of DLT we need to use for our patients? This is decided on 3 or 4 parameters. First of all, when we look at the age. When we see the age of the patient, a child who's 8 to 10 years of age will need a 26 size tube. Somebody who's 10 years of age will need a 28 size tube. Somebody who's 12 years will need 32. And somebody who's 13 to 14 years of age will need a 35 size tube. When we look at the height of the patient, somebody who's more than 150 centimeters generally needs a 35 to 37 size tube. Somebody who's around 180 centimeters will need a 37 to 39. And somebody who's more than 180 centimeters usually needs a 39 to 41 size tube. And when we look at the tracheal width, depending on that, this tracheal width can be measured either on the CT scan or the chest X-ray. And when we see that, again, we can see that somebody who has a tracheal width of around 15 to 16 millimeters will need a 37 or a 39 tube. Less than that will need a 35 tube, and somebody more, having a wider tracheal width will need a 41 size tube. To decide the depth of insertion, at what depth the tube needs to be fixed, it is a very simple thing that we need to remember, that for 170 centimeters in height, the tube depth of 29 centimeters is required. And for every 10 centimeters change in height, a 1 centimeter depth change needs to be added. That is, if the patient is 180 centimeters, we may need to fix it at 30 centimeters. And if the patient is 160 centimeters, we may have to fix it at 28 centimeters. But these are all studies which have been done on in the Western population. When we look at our own subset of patients, we realize that most of our patients, generally, if we look at women, they need a 32 or a 35 tube. And when you look at men, they generally need a 35, 37. Very rarely we see that a 39 or a 41 tube size may fit the Indian subset of population. Again, when we see, if we want to corroborate the tracheal width with the predicted left bronchus diameter, we see that the left bronchus diameter also changes in correspondence to the tracheal width. And the smaller the tracheal width, the lesser is the left bronchus diameter. And hence we need to choose a smaller size of tube in these group of patients. When we look at the external diameter, this is the external diameter of a normal endotracheal tube, and this is of a double lumen tube. When we see the external diameter of a normal 8 size endotracheal tube, it corresponds to a 35 French tube. Whereas it is a 10 size of an endotracheal tube, which is going to correspond to a 41 French tube. So we need to understand that, when we are selecting, another thing that we need to know, when we select the size of the DLT, we should have an idea as what size of an normal single lumen endotracheal tube we are going to use. Because if we are going to use a 7, 8 or an 8.5 tube, then it will correspond to something like 32 to 35. It's only in, when you have very large trachea of around 9 to 9.5 that a 37 or a 39 tube can be used. And if we want to know what size of fiber optic bronchoscope we can use, we need to remember that, in most of our patients, and when we are using the normal size of adult tubes, something which is less than around, around 3.5 is what is needed. But if we are using pediatric tubes like the 26 or 28, then much smaller neonatal size of bronchoscopes, that is, which is 2.5 in size, is what is going to go inside that DLT. I will discuss the technique of intubating the patients with a DLT later. But once we have intubated our patients, we have to ensure the correct position of the DLT. And this we do first, obviously, is always clinically, where we will auscultate and listen to the breath sounds that they are normal, and we can see here bilateral on both the sides. After that, we follow the expected unilateral pattern with unilateral clamping. The chest should rise and fall in accordance with the breath sounds. The ventilated lungs should feel compliant with no leaks present, and the respiratory gas moisture appears and disappears with each tidal ventilation. Even after, but always remember that once we have confirmed clinically, a fiber optic bronchoscopy must be done, because in 38 to 78% of the patients, we will find out that the tube still needs some kind of adjustment or positioning. This is the view that we will get when you do a fiber optic bronchoscopy. When we see a left-sided double lumen tube and we have passed the bronchoscope through the trachea, what we see first is that the left-sided tube with the bronchial cup going into the left side. And here we can see this trachealis muscle, and this tells us that this is the right bronchial lumen. So this shows that the tube is been adequately placed. And then when we pass the bronchoscope into the right side, we can see the outshoot or the right upper lobe bronchus. And when we pass it through the bronchial lumen, we can see the secondary carina, which is clearly seen, where we can see the division of the left bronchus into the upper and the lower lobes. And when we see it through a right-sided tube, again, what we can see to the right DLT, when we pass it through the bronchial lumen, we should always ensure that the slot has been aligned towards the right upper lobe, so that the ventilation to the right upper lobe is continued. And we can see the division of the the right side into the middle and the lower lobes. And we can see the tube going in onto the right side, the bronchial cuff going into the right side. Nowadays, what we have is the Viva side DLT, which is available in adult sizes. In the Viva side DLT, which is available, we have the tip, we have a camera which is inserted in the tracheal cuff, and hence we don't have the need to do a bronchoscopy along with it. And this camera tip guides us and helps us to identify the position of the tube, and we don't have to do a bronchoscopy. And these Viva side DLTs are now available in our country, but at present they are only available in the adult size. The second thing, that if we don't have a DLT or it's a child, then what we can use is something which is known as the bronchial blocker. The lung separation can be effectively achieved with the use of a single lumen endotracheal tube and a fiber optically placed bronchial blocker. This is especially useful in children because the DLTs are too large, and the smallest DLT that we have is a left-sided 26 tube, which may be used in a child who's 8 to 12 years of age or weighing at least 25 to 35 kg. These bronchial blockers have the advantage of allowing suction as well as injection of oxygen down the central lumen. The indications for bronchial blockers includes limitation to the use of a DLT. For example, if there is a severely distorted airway, a tracheostomized patient, children, or anticipated difficult intubation. To avoid change of the DLT into a single lumen whenever post-op ventilation is anticipated, or in a thoracic spine surgery where you have to change the position of the patient multiple times, maybe initially in supine, then lateral, and also maybe the surgery may be followed in the prone position, and situations where we have to operate both the lungs simultaneously, one after the other. The various type of bronchial blockers available are the ART blocker, the Cohen tip blocker, the uni blocker, which we have in our country is the Kubdek, and the EZ blocker or the EZ blocker. The characteristics of these blockers, which we need to understand, is one is that they are all available only in the for the adults. Only the ART blocker is available in size 5. The others are all available only in the adult sizes. The difference in all of them is the mechanism by which we will position these blockers. For example, in the ART, there is a nylon loop which is present, which is used to guide the blocker in place. In the Cohen, there is a tip deflecting wheel, whereas in the uni blocker or the Kubdek, there's a pre-angled tip. And the EZ blocker, it has a distal Y tip that it has two, it is a Y-shaped thing where we guide the bronchial lumens into the place. And depending on the side we want to block, that side of the bronchial cuff can be inflated. So this is what a uni blocker or a Kubdek blocker looks like. As we showed that it has an angled tip, it has a multi-port connector through which we can ventilate the patient as well as pass the bronchoscope. And then there is a cuff, there is a pilot balloon to inflate the cuff and a central lumen through which we can oxygenate or do suction. This is how a Kubdek blocker looks like once it is in position. This is an EZ blocker. As we said, it is a Y-shaped blocker where we can see that, it has two bronchial cuffs and both of them can be positioned into the into the bronchus. And the one which the side which has to be blocked can be inflated. And this is the ART bronchial blocker. As we said, it has a nylon loop in which which is pulled and tied over the bronchoscope, and this helps to guide this blocker in place. It also comes along with a multi-port adapter through which we can continue our ventilation, pass the blocker, and as well as do the bronchoscopy simultaneously. Other than that, if you have really very small children or you don't have a blocker available, then the Fogarty embolectomy catheter with a 3 ml balloon can also be used. It has a stillet so that it is possible to place a curvature at the distal tip to facilitate its movement in the larynx and enter the mainstem bronchus. And at times, the Foley's catheter and Swan-Ganz catheters have also been used. The disadvantage with them is that they are not very easy to place because they do not have any guiding mechanism can be used. But the advantage is that if you really have very small children, then you can also place them coaxially. That is, you don't have to, put them intraluminal inside the tube, but alongside the tube, they can be passed and they can be used for isolating the lung. The other advantage with these blockers is that they can be used for selective lobar isolation or, blocking the subsegmental bronchi, especially if we want to oxygenate that area or we want to protect that lung from any damage or spillage of the contaminated material. The disadvantage of these compared to the DLTR, there is times it may be difficult to suction or ventilate the lung distal to the blocker. It requires more placement time. There is a definite need for a fiber optic or a rigid bronchoscope to place them. And the most dreaded complication is that if this bronchial blocker backs out into the trachea, the seal between the two lungs will be lost and the trachea will get partially obstructed and ventilation is impaired. And this can, really block the ventilation to both the lungs. And if we don't know of this complication, the patient may arrest and we may not know what the cause is as to why we have lost the ventilation in this patient. The third kind of tubes that are available for us are the univent tubes. The univent tubes are basically endobronchial tubes or you can say single lumen tubes with the bronchial blocker incorporated in them. They are easier to insert and can be positioned properly. Also during continuous ventilation and in the lateral decubitus position, there is no need to change the tube when we are changing the position of the patient from supine to prone, or if we also have to shift the patient post-operatively on mechanical ventilation. And selective blockade of some lobes of lungs can also be provided. The other thing is there is a possibility to apply CPAP to the non-ventilated operative lung. So this is how a univent tube looks like. We can see that it basically has a single lumen tube in which we have a blocker, which is a part of this tube. Again, it will have two cuffs, a tracheal cuff and a bronchial cuff. And in this bronchial cuff, there is a hollow lumen so that suction as well as oxygenation can be provided. And we can guide this the blocker on the desired side that we want to block. Now I'll show you a small video to show you the technique of how these tubes have to be inserted. Always remember that the technician has prepared the tube and kept it ready and the connector has been placed. Always do it in the aseptic condition and ensure that asepsis is maintained. The technique of the double lumen tube insertion is that the bronchial cup should be facing concave upwards, and always ensure that you have seen the vocal cords before you place the tube, because they are relatively large and may cause end trauma. Once we have passed through the vocal cords, remove the stellate and rotate the tube on the side. It has to be placed 90 degrees if on to the left if it's a left-sided tube, or towards the right if it is a right-sided tube. Once the tube has been positioned and is in place, inflate the tracheal cuff first, and then connect the multi-port connector. This multi-port connector now, which comes, is also color-coded, so that it's easier for us that we are connecting the bronchial, lumen to the bronchial port, and the tracheal to the. They are also color-coded, the blue and white. And after we have inflated the tracheal cuff, we will now inflate the bronchial cuff, but with only 2 cc of air. And then, as I said, first we always have to do the clinical inspection of the placement of the tube. That is, we will ventilate and auscultate bilaterally both the sides to see that the entry is good, the lungs are compliant, and we can hear the breath sounds, and we have the capnograph or the trace available with us. Once we have confirmed that the tube is adequately placed, and the tube has to be pushed only till the time where the resistance is felt. And then we will start clamping. Always start with clamping the tracheal side first. Once we have clamped it, then auscultate on each side respectively to see that it follows the side of unilateral clamping, and chest rises and falls according to that. After we have clamped the tracheal side and we have seen that, okay, the entry is adequate, we now clamp the bronchial side. When we are doing all this, the few things that we have to note is that the lungs are compliant. We do not find any excessive resistance. Also, simultaneously, there are no leaks, and we are able to deliver the tidal volume which is required. After we are happy with our clinical confirmation, then we should always do a fiber optic bronchoscopy to confirm the position of the tube. The bronchoscope should be adequately prepared. We should see that the tip is clean, and if it has been used before, then always flush it. There is a knob, and always check the movement of the tip of the bronchoscope to see that it is working. It also has a suction as well as an oxygenation port. Always connect the suction when you are doing the fiber optic bronchoscopy. Pass your bronchoscope first through the tracheal lumen. Once we pass the bronchoscope through the tracheal lumen, we will be able to see the carina. And then in a left-sided DLT, we will be able to see that the bronchial lumen is there on the left side in the left bronchus. And here we can see that this is the carina, the tracheal lumen of the left-sided double lumen tube. And we can see that this can also be identified with the help that we can see the trachealis muscle. And this trachealis muscle basically goes into the right side and helps us to identify the right and the left. The other way of obviously identifying is that once we go into the bronchial lumen, we can see the divisions of the right and the left bronchus accordingly. When we look into the right DLT, what is important for us is, one, is to see that the tube is going into the right bronchus. The cuff of the bronchial lumen should not be overinflated so that it does not herniate to the other side. When we go into the left bronchus, we should see the secondary carina. This is called the secondary carina, where we can see the division into the left and the upper lobes. This is how we can differentiate the right from the left. And when we insert it into the right side, we can see that the slot has been aligned towards the right upper lobe so that it gets ventilated well. Let's see now the insertion of a Coupe blocker. As I said, a Coupe blocker has an angle. The angle is twisted. So the rotation, the technique for insertion of this is basically you have to twist it in the desired direction, and hence we can place the tube. Again, we see that it comes with a multi-port connector. One part of it gets connected with the endotracheal tube, through which we will pass the blocker. We have to see that it moves in easily. Then one port is connected for the ventilation, and through the third port, we can pass the fiber optic bronchoscope. An important thing which we need to realize when we place the bronchial blockers is one is that we always need a bronchoscope. And secondly, we should ideally place the endotracheal tube slightly above the carina so that there is space left for us to maneuver the bronchial blocker towards the side that we want to block. If there is not enough space, then we will find that we do not have enough, if the distance between the carina and the tip of the endotracheal tube is not much, then there may be difficulty in placing the blockers because we don't have enough space to maneuver it. So once we pass this blocker into the trachea. Then we twist it in the desired direction on which side we want to block the tube, and which side, sorry, we want to block the lung. So accordingly, it is, we can, here, as you see, you can be going to the right side. We take it out into the lumen, we twist it, and then we can push it to the left. And then the balloon is inflated and the lung on that side can be isolated. Now I will next show you the video of how to place an ARNT blocker. The ARNT blocker, as I told you, is a special kind of a blocker. It also comes with a multi-port adapter. And as you can see that it has a nylon loop. This multi-port connector is again connected. One end is connected to the patient. One is for ventilation. And the third one is through which we are going to pass the bronchoscope. Before we start, inserting the blocker, we have this nylon loop through which the bronchoscope should pass. It has to be tightened and this bronchoscope is snugly fitted over it. The tip of the bronchoscope generally lies ahead of the blocker, so it helps us to guide the blocker in position. And then when we do the bronchoscopy and we have identified the right and the left sides with the help of the bronchoscope, we guide the blocker in place accordingly. It is pushed ahead and guided in place. And once it is in place, this nylon loop is loosened. The bronchoscope is pulled back, and then we can inflate the balloon and identify that the balloon is inflated and is in the right place. And then the bronchoscope can be pulled back. The port has to be fixed or tightened so that the blocker does not move in place. In the coupe type blocker, because there is no fixing mechanism, generally we put a mark on it to ensure that the tip, it has not moved during positioning. And then finally, when we talk about these embolectomy catheters or Fogarty catheters, we find that they are generally very difficult to manipulate. So they may not be ideal techniques or devices for lung isolation. But yes, at times, if you want to do a selective lobar isolation or oxygenate a particular portion or a lobe of the lung, then they can be used. But generally, they take much longer. And also because the cuff volume is much less, they may not really always provide an adequate seal in the adult group of patients. Here we can see that this was a patient of an hydatid cyst, and because we wanted to prevent spillage of the contents of the hydatid cyst, so we used selective lobar isolation, and hence a Fogarty catheter was passed to provide us with that. So now after discussing all these devices, we have a question for the students who are available with us, and if they could answer it and tell me what are the advantages.
Sorry, shall I read it for you? Yeah.
Sure.
Thank you, ma'am. Following are the advantages of bronchial blockers over DLT, except A, can be used with different airways, endotracheal tube, LMA, tracheostomy tube. B, allows selective lobar isolation. C, easy and quick placement and maintenance. D, easy return to two-lung ventilation and post-op if needed. Please type your answers in the chat box. And we're already receiving a lot of C's. That is easy and quick placement and maintenance. Everybody has answered C.
Yeah, so I think that is the correct answer. And so that makes me feel good that everybody is listening to what I'm saying. So I think, yes, that is the advantage of bronchial blockers over the DLT, that except that they always take longer to place because you need a fiber optic bronchoscope and you have to place them in the correct position and you have to ensure that they are providing a good seal. And they are also the ones which are most easy to get displaced, especially when you are changing the position of the patient. So if I have to summarize this, I would say that the DLT is the gold standard or method of choice for lung separation in most adult patients, but the precise location has to be determined by a fiber optic bronchoscope. In situations where insertion of a DLT may be difficult or dangerous, separating the lungs can be achieved with either a single lumen tube alone or in combination with a blocker, example, the Univent tube. But regardless of the method that we use for lung cell separation, there is always a real-time need of a small diameter fiber optic bronchoscope to check the position of the DLT, whether it or the position of the blockers or an endobronchial tube. And also we need the fiber, this position has to be checked first in the supine position. Then again, whenever there is a change in position, for example, if we move the patient to the lateral position or we change it to a prone position. So again, whenever the position has been changed, we always have to check the position of the tube as well as the blocker, or at any time we feel that the patient is becoming hypoxemic or we are not able to maintain the saturation, then a fiber optic bronchoscopy should always be performed. So now I'd like to move into the next part of my talk, which is about one lung ventilation. Once we know what are the devices that we use for isolation of the lungs, we have to understand what is one lung ventilation and how is it that we can take care of this lung which is undergoing surgery as well as being ventilated. So when I was preparing this topic, there was an interesting thing that came up, which says something which is known as the mountaineer's dead zone. A mountaineer's dead zone is something that at 8,000 feet, if a mountaineer is not provided with supplemental oxygen, he is going to develop lung injury and succumb to it. So similarly, they have said that if during one lung ventilation, we are not going to take care of the lungs of that patient, which is undergoing surgery and is under anesthesia, and provide oxygen to it or take care of all the parameters or provide that protective lung strategy, this patient is also going to develop hypoxemia in the post-operative period. And also he can develop something which is known as the acute lung injury, which we know is the most dreaded complication and and also results in high morbidity and mortality, and one of the most common cause of the post-pulmonary complications which we see in this group of patients. So let us first talk about the physiology of the lung before we actually start talking about one lung ventilation. We all know that when we are standing upright, we know that the lower part of the lungs, the ones because of the positive pressure, the alveoli are collapsed, and hence they lie in the steep part of the lung compliance curve. So most of the ventilation or preferred ventilation goes to the bases. And this is what happens if we lie down and we are in the lateral position. So in somebody who's lying down and is in the lateral patient, or is, the patient is awake and breathing spontaneously or non-paralyzed, it is the dependent part of the lung which lies in the steep part of the lung lung compliance curve. That is, most of the ventilation is going into this dependent lung. This is a good thing for us because because the perfusion also because of the gravity is also going into this dependent lung, and hence the shunt fraction of what we can say the dead space ventilation is reduced. But what happens is this happens only when the patient is not paralyzed. The moment the patient is paralyzed and, because of the decrease in the FRC and the loss of the chest recoil, what happens is that this dependent lung now moves into the flat portion of the lung compliance curve. That means the preferred ventilation is now going into the non-dependent lung. And so what happens is the ventilation is going into the non-dependent lung, but the perfusion is still in the dependent lung, and hence the shunt fraction keeps on increasing and we are not able to maintain ventilation. But the moment we isolate this lung and send the ventilation into this dependent lung, again our shunt fraction is reduced and we are able to restore the oxygenation which was happening. So the ideal situation is that if we have to place a patient in one lung ventilation, the lung should be isolated so that the ventilation and perfusion are going into the dependent lung. So if we have to operate a patient, for example, in the supine position, it will be difficult to maintain his oxygenation as compared to a patient in the lateral position. And in the lateral position also, a left thoracotomy is better tolerated than the right thoracotomy because we know that the right lung is bigger and 60% of the perfusion and ventilation goes into the right lung. So what I would like to say is, after induction of anesthesia and muscle paralysis, there is a decrease in FRC and loss of the muscle tone in the chest wall and diaphragm. With the lateral decubitus position, the dependent lung compliance is shifting most of the ventilation towards the upper lung, and pulmonary perfusion preferentially goes into the dependent lung due to gravity. But once the lung is isolated and one lung ventilation is instituted, both ventilation and perfusion will go into the dependent lung, hence reducing the ventilation perfusion mismatch. So yes, Monica, we have the next.
Yes, ma'am. Which of the following patients undergoing surgery with one lung anesthesia will maintain oxygenation easily in intra-op period? A, right lateral decubitus with left lung down. B, left lateral decubitus with right lung down. C, supine position with left lung down. D, supine position with right lung down. So Dr. Rahul, Dr. Purnima, Dr. Pranav, they all are answering B. Dr. Gauri, Dr. Priya, Dr. Nupur. I think everyone has answered B. Dr. Pradeep, Dr. Shagufta, Dr. Tanya, Dr. Pankaj, Dr. Anu.
Yeah.
Yeah.
So so that is the correct answer. It's B, as I described earlier, because that what happens is, one is that the right lung gets most of the ventilation and perfusion, and secondly, the lateral position is preferred over the supine position, basically because it reduces the ventilation perfusion mismatch. So now let us look at step by step as to how we can maintain one lung ventilation. So to start with, induction of anesthesia till the time we initiate one lung ventilation. We know that once we have induced our patients, de-recruitment occurs, and alveolar recruitment maneuvers improve oxygenation and ventilation during two lung ventilation, and this effects persists also into the period of one lung ventilation. So an ARM just prior to OLV increases the aeration as well as the compliance during one lung ventilation. Furthermore, it decreases the risk of atelectotrauma. So once we have induced a patient, before going into one lung ventilation, two things which we need to keep in mind is, one is perform an ARM, that is an alveolar recruitment maneuver, and secondly is ventilate that lung with an FiO2 of 1, because if we are using an air oxygen mixture, the nitrogen that is present takes much longer to diffuse out, and hence the lung will take much longer to collapse as compared to when we are using a FiO2 of 100%. So these are the two things we need to keep in mind before we initiate one lung ventilation. Now, once we have decided that, okay, the surgery is about to start and we have to maintain OLV, what are the factors that we need to keep in mind? The various factors that we need to keep in mind, I have divided it into, all the parameters that are there. That is the tidal volume, PEEP, FiO2, the IE ratio and respiratory rate, the ARM, hypercapnia, the pressures, and the ventilation modes. And I'll discuss each of them one by one. So initially it was thought that, the excessively large tidal volume, that is 15 ml per kg, was good because it prevented the alveoli from collapsing and also reduced the atelectotrauma. But then it came down to no, this was not good, and the incidence of pulmonary complications were quite high. So it came down to large tidal volumes, but again, this was not really beneficial in these group of patients. And now what we use these days is the protective lung ventilation, that is using a tidal volume which is less than 8 ml per kg. And this is what is used these days. So a protective lung ventilation strategy of using a tidal volume of less than 8 ml per kg. And Licker et al. Very clearly showed the impact of using this lung protective strategy of a tidal volume of less than 8 ml per kg, where he found that the incidence of acute lung injury, atelectasis, as well as ICU admissions was much lower as compared to his previous cohort or historical patients where conventional ventilation was used. Similarly, Schilling et al. Also showed that when the patients had received a tidal volume of 10 ml per kg, they had increased cytokine levels as well as extravascular lung water measurements. So most of the studies do show that a low tidal volume protects the lung from injury. And it also improves oxygenation, but this only happens when we have used adequate PEEP. So one thing that we need to keep in mind, that if we are using low tidal volume, we have to provide adequate PEEP to maintain to improve the oxygenation, because low tidal volume without PEEP is going to worsen the oxygenation. And how do we calculate this predicted body weight? The predicted body weight in males is calculated as 50 kg plus 2.3 into height in inches minus 60, whereas in females it is calculated as 45.5 plus 2.3 into height minus 60, height in inches minus 60. And this was a very recent publication from Randall Blank et al., who have clearly shown that if we are just using a low tidal volume without sufficient PEEP is not good enough. It is as good as using a conventional mode of ventilation or the conventional tidal volumes. It is only when we are using it in the presence of sufficient PEEP that the oxygenation is going to improve, and it is going to reduce the post-op pulmonary complications. So is PEEP always beneficial? I think we need to discuss about that also. So PEEP is beneficial in patients whose intrinsic PEEP is well below the lower inflection point on the compliance curve, that is patients who have a normal lung function. And this has to be titrated to the lowest driving pressure. I shall tell you about driving pressure later. That is, it should be less than 15 centimeters of water. And Valenza et al. Clearly showed that patients who have a normal LV function, the PEEP improved, the oxygenation improved when the PEEP of 10 centimeters of water was applied. So what do we mean by this is that, in patients with COPD, they have an auto PEEP which is there. So if we apply an extrinsic PEEP to this, one is it is not homogeneously distributed throughout the lung. And secondly, what happens is that when there is an auto PEEP and we apply external PEEP, the total PEEP moves the alveoli away from the lower inflection point. And if the alveoli are moved away from the lower inflection point, they do not, they do not expand properly. In fact, the PVR increases. But in patients who have a normal LV function, and because they have a low intrinsic PEEP, with the addition of the external PEEP, the total PEEP moves these collapsed alveoli towards the lower inflection point, and hence reduces the FRC and improves the oxygenation. So this shows the clear relationship that if we have applied too much of PEEP and the alveoli are moved away from the lower inflection point, the PVR will increase because of the increase in the resistance of the small interalveolar lung vessels. Hence, the PEEP has to be decided on the basis of the, the auto PEEP that is being generated and the kind of lungs they are, whether it is a patient of COPD or it is a restrictive lung disease or a patient who has normal lung functions, and then decide the kind of PEEP that is required. So we cannot always say that PEEP is beneficial, and we also need to decide the amount of PEEP which needs to be given, because too high levels of PEEP may cause dynamic hyperinflation and also cause hemodynamic instability. Then we talk about FiO2. And one thing that we need to remember in these patients is that a saturation of 92% is acceptable. In patients undergoing lung transplant or who have been on adjuvant therapy, a low FiO2 of 0.21 is advisable. As a routine practice, initiate one lung ventilation at a high FiO2 of 0.8 to 1, but then titrate it to as low as 0.4 or 0.3 also according to the SpO2 levels. Why high FiO2 should not be used is because it results in the production of reactive oxygen species and inflammatory cytokines. And oxygen toxicity also occurs because of the ischemic reperfusion injury due to the lung manipulation and collapse. And this may further initiate tissue hypoperfusion. And prolonged OLV and generation of oxidative stress has also been associated with increased rates of respiratory failure, cardiac arrhythmias, and hypertension. And high FiO2 also leads to absorption atelectasis. ARMs I described earlier also, they have to be initiated before starting one lung ventilation, but intra-op also during one lung ventilation also these maneuvers may be indicated if there is a decrease in saturation or the lung compliance is decreasing. And if there is improvement in oxygenation or lung compliance after an AM, it indicates that there is an inadequate level of PEEP which was being used. And this was a study by Tusman et al., which clearly showed that if we used an ARM during one lung ventilation, the PO2 levels increased from 144 to 244 in their group of patients. This clearly shows the patient who was on two lung ventilation and then on one lung ventilation without an ARM, and then after a alveolar recruitment maneuver is used, the PO2 levels increased. Similarly, the study by Jung et al. Has shown that the use of ARM not only improves the oxygenation, but it also reduces the incidence of post-op pulmonary complications. Now talking about the ventilatory strategies that are available to us, the modes of ventilation that we should be used. We know that we have always been conventionally starting using pressure control, volume control mode of ventilation. But there have been studies which have now shown by Montes et al., which clearly shows that whether you use volume control ventilation or pressure control ventilation, there is not much difference if we are talking of a patient who has normal lungs and is healthy and does not have any restrictive or obstructive lung disease. But if we have somebody, who has some kind of respiratory failure or respiratory disease, then it has been observed that the pressure control mode of ventilation is much better than volume control ventilation because of the lower airway pressures, that is the peak airway pressure and plateau pressures. And the oxygenation is also much better in pressure control mode of ventilation. But now with the newer ventilators, we have something which is also known as the pressure control ventilation with volume guarantee. And this was a study by Lin et al. And they also showed that if we using pressure control ventilation or a pressure control with volume guarantee, the oxygenation as well as the airway pressures were much lower and the oxygenation was much better, especially in the elderly group of patients. So if we have, most of the studies are equivocal on what mode of ventilation we use. But one thing we need to remember is if we have a patient who is at high risk or he is elderly, then definitely a pressure control mode of ventilation is beneficial. But yes, if we have a patient who has a normal lung function and is healthy, lungs are healthy, and it is just, some kind of a small procedure that is being carried out, then a volume control mode of ventilation can also be used. And this is again a study by Bools et al., who have also shown that the pressure control mode of ventilation decreases the inspiratory parameters and improves arterial oxygenation better than volume control ventilation, especially if you have high risk group of patients. But these days, what we have now is the driving pressure ventilation, which should be used. What is the driving pressure? The driving pressure is the difference between the plateau pressure and the peak pressure. And this pressure, if it is less than 15 centimeters of water, it has been found that it is much better than conventional ventilation because it decreases the risk of post-op complications as well as acute lung injury. So what, so if we look over the years from volume control to pressure control to pressure control volume guarantee, what we are now using is this driving pressure ventilation. And this is what we should be using for all our patients. That is, we have to calculate this driving pressure and keep it as low as possible if we want to reduce the incidence of acute lung injury. Another important thing that we know is that hypercarbia is present in all these patients who are undergoing one lung ventilation. And we also know that it has a protective and a beneficial effect on the serum cytokine levels as well as free radical injury. The moderate hypercapnia also potentiates the hypoxic pulmonary vasoconstriction response. And PaCO2 levels up till 70 millimeters of mercury are very well tolerated unless the patient has some kind of cardiac comorbidity or pulmonary hypertension or increase in the ICP. When we talk about the IE ratio and the respiratory rate, patients with obstructive lung disease need longer expiratory time than those with restrictive lung disease. And also a higher respiratory rate increases the potential of auto-PEEP, dynamic hyperinflation, and dead space ventilation. Hence, we should decide on the IE ratio and the respiratory rate, again, depending on the lung condition. The peak and plateau pressure should be kept as low as possible because the peak inspiratory pressure is a measure of the dynamic compliance, whereas the plateau pressure is a measure of the static compliance of the lung. A peak inspiratory pressure of 35 to 40 centimeters and plateau of less than 25 are associated with reduced risk of ALI. And Licker et al. Noted that if the plateau pressure was more than 25 as compared to those who had 15 centimeters of water, they had a threefold increase in the risk of acute lung injury. So yes.
So, during one lung anesthesia, lung protective ventilation strategy includes all except A, low tidal volume, 4 to 6 milliliter per kg. B, recruitment maneuver and PEEP less than or equal to 5 centimeters of water to dependent ventilated lung. C, FiO2 of 1. D, permissive hypercapnia. Please type your answers in the chat box. And we are getting the answer as C. Dr. Hina has said A. Dr. Ravi, Sonika, Bhuvneshwar, Dr. Vijaya, Dr. Anu, Dr. Naira, Dr. Pankaj. Everyone is answering C.
Yes, so it is C. Basically, we should not use high FiO2s because, as I mentioned, that high FiO2 will cause damage to the lungs because of the release of the oxidative reactive oxygen species as well as the absorption atelectasis. So use FiO2 as low as possible, which we need to maintain adequate saturation. So to summarize our protective lung strategy, what does it include? It includes a tidal volume of 4 to 6 ml per kg. But if the patient is hypoxic or severely hypercapnic, consider 6 to 8 ml per kg. PEEP, depending whether it is a protective, restrictive, or a normal lung, it may vary from 5 to 10 centimeters of water. For obstructive lung disease, it may go down to 2 to 5 centimeters of water. The respiratory rate is usually between 15 to 18 beats per minute. The FiO2, if it's a transplant, 21%, but routine, it's around 40, I would say 40 to 50%. Only if the patient is hypoxic, go to 100%. The IO ratio also will depend on whether it is a restrictive lung disease or an obstructive lung disease, varying from 1:1 to 1:3 to 4. The airway plateau pressures as well as the peak pressures have to be less than 20 and 35 respectively. Minute ventilation so that your PaCO2 is maintained between 50 to 70 millimeters of mercury. And the ventilator mode, as we said, was initially we had come up to pressure control volume guarantee, but nowadays it has to be the driving pressure mode of ventilation. When we are talking about one lung ventilation, a few important things which we also should know during maintenance of anesthesia is that initially inhalational anesthetics were considered detrimental for one lung ventilation, but now the newer inhalational anesthetics have less effects on the HPV, and in fact they appear to be lung protective. It's just that very high MAC should not be used. And with OLV, a pro-inflammatory reaction takes place, which is exhibited by increased levels of cytokines in the bronchoalveolar lavage samples in either of the lung. So when we compare it with propofol anesthesia, these anesthetics have shown to attenuate this cytokine elevation. And another thing which we need to keep in mind is that a euvolemic fluid strategy must be used. Once the surgery has been performed and it is time that we have to extubate our patients, then re-expansion of the operative lung with lung recruitment at the end of surgery helps in various ways. It restores the normal lung function and helps, and it is necessary to re-establish the pleural interface. It minimizes any post-operative pneumothorax, and ARMs optimize post-op pulmonary function and reduce the VQ mismatch. But a caution should be taken that we do not disrupt the staple lines, and hemodynamics instability may occur because the patient at this point of time may be relatively hypovolemic due to the blood loss that may have occurred during the surgery. The lung re-expansion can also sometimes worsen the lung injury due to the ischemic reperfusion syndrome and the release of reactive oxygen species and oxidative stress. And a low FiO2 should be employed, as hypoxemic reperfusion has been shown to attenuate the inflammatory response and organ injury. The two-lung one vital capacity maneuver is undesirable because it will cause over-distension and volute trauma in the more compliant non-operative lung. And sometimes if the surgery has been going on for too long and if we need it, the lung has to be expanded in a graded manner. That is, we slowly increase the pressures from 10 to 15 to 20. It's not that, we just inflate the lung to 20 centimeters of water. And at times, if we need higher pressures to inflate that lung, then we may use another circuit or transiently isolate the non-operative lung so that the targeted pressure goes to this atelectatic operative lung. So why we have been talking of all this is basically because we want to avoid this most dreaded complication, which we know is acute lung injury, which is diagnosed by an acute reduction in the PF ratio to less than 300, presence of bilateral pulmonary infiltrates on chest radiograph in the absence of left heart failure. It is the leading cause of death after thoracic surgery, and there is evidence that a good OLV management can influence and reduce the severity of this complication. And it is a complex interaction of over-distension, that is volute trauma of the alveoli, increased transpulmonary pressures, that is barotrauma, the cyclical opening and closing of the alveoli, that is atelectotrauma, and the release of the multiple inflammatory mediators, that is known as biotrauma. And this villi can exacerbate the existing lung injury that is present or sensitize the normal lung to further injury. And basically, there are various studies which tell us that if we have used a good intraoperative mechanical ventilation strategy, it is going to reduce this incidence of ALI. And this was a study which Liu et al., which showed that, if use of protective lung ventilation as compared to conventional ventilation reduce the incidence of post-pulmonary complications. But whether you use PCV or VCV, it made no difference. Similarly, another study which was published by Mitchell et al. On patients undergoing esophagectomy clearly showed reduced levels of inflammatory biomarkers in these patients who had received a protective ventilatory strategy, and it improved the pulmonary function and resulted in earlier extubation. Again, Della Rocca in their review have very clearly said that it is not only the tidal volume which is a part of the protective lung strategy. When we talk about it, it is a combination of the FiO2, the P, the ARMs, and these together, when used, are going to reduce the incidence of ALI in patients undergoing thoracic surgery. Another important thing which we need to keep in mind is also the duration of one lung ventilation which we provide, because a duration of less than 150 minutes is found to be useful, but the moment it is more than 150, the risk of complications and ALI goes up. So if we look at the predictors of intra-op hypoxemia, when we look at patient factors, this could be a prior surgery that he had, a patient who has a very good healthy lung function, patients who are on chronic vasodilator therapy, or who have poor oxygenation or are on ventilators in the pre-op period, sepsis. When you look at procedures, I think we've already discussed a right-sided surgery, supine position, or too much use of volatile anesthetics are also going to be predictors of intraoperative hypoxemia. If a patient does develop hypoxemia, then what is it that we are going to do? First is increase the FiO2 100%. If it is life-threatening, stop the surgery and resume bilateral ventilation. But if it is not life-threatening, continue with one lung ventilation. First, look at the treatable causes, which is that look at the position of the DLT, look for secretions, blood or mucus, look at the hemodynamic parameters. Maybe the blood pressure is low because of blood loss, too much of use of the depth is too high, or there is right ventricular dysfunction which is developing. If there is no treatable cause identified, then see how we can improve the oxygenation. That is first by optimizing the ventilation, which can be done by increasing the FiO2 or 200% and giving oxygen to the operative lung, providing CPAP to that lung, or increasing the PEEP to the dependent lung. Or we can optimize the perfusion, which can be done with the use of inhaled prostacyclines or use of nitric oxide, clamping the pulmonary artery, or use of pulmonary vasodilators. This is a CPAP circuit which can be applied to the operative non-dependent lung. At times, if the oxygenation is still not maintained, we can do a selective lobar oxygenation. That is, if the surgery is going on in the left upper lobe, as I said, we can use a Fogarty or a very small catheter and through the bronchoscope guide it into the left lower lobe and selectively provide oxygenation to the left lower lobe. The other techniques that have been used, for example, if you're doing tracheal or carinal surgeries, then high frequency jet ventilation can be used because it delivers very small tidal volumes at high rates. It can be delivered through the help of very small catheters and it decreases the PAWP. It is especially useful in facilitating thoracic surgeries of the conducting airways, or if there is a bronchopleural fistula, because there is minimal movement of the operative field. The other thing that we can also use is low flow apneic ventilation, because if for example, again in major tracheobronchial repairs, if the ventilation is stopped, then administration of 100% oxygen because of the mass movement, it is going to move into the blood, and there is no difficulty in maintaining an adequate PO2, especially 5 to 10 centimeters of CPAP is also used for 20 minutes. And the CO2 that gets produced initially rises by 6 millimeters in the first minute and then 3 to 4 millimeters afterwards. So a safe period of between 15 to 20 minutes can easily be used for the surgery to go on by using low flow apneic ventilation. But the arterial oxygen saturation monitoring is mandatory in these group of patients. And in these group, and now recently the ECMO is also being used in quite a few thoracic surgeries, especially if you have surgeries which are in the carina, or those where you have large mediastinal masses which are involving the great vessels, the SVC or the pulmonary artery. So to perform those kind of mediastinal mass surgeries, where you may think that there may be some kind of hemodynamic instability, or even you may have difficulty in maintaining ventilation, then the ECMO can also be used as a tool to maintain oxygenation in some of your patients. So, okay, Monica, so now.
Yeah, so I'll read out the first scenario. There is a 60 years male patient with lung cancer. He's a smoker, and a left thoracotomy has to be done. Right DLT, left upper sleeve. Okay, I think the patient has already underwent left thoracotomy.
He's undergoing left thoracotomy with a right DLT in place.
And left upper sleeve lobectomy.
That is the surgery.
Yeah.
And there is uneventful lung ventilation till the hilar dissection, but suddenly there is an increase in the airway pressures. The tidal volume decreases, the vitals are maintained, but there is a drop in saturation. So what are we going to do?
So how to troubleshoot the situation?
Yes.
So shall we unmute the participants? You can just raise your hands.
Yeah.
Or you can type your answer in the chat box.
They can tell us step by step what is it they will do. What will they do first, then second, and what do they think is the probable cause?
Please type your answers in the chat box. So Dr. Hina is saying increase FiO2.
Okay.
200%. The same answer is given by Dr. Monica.
What do they think is the probable cause?
So Dr. Mukesh is saying I peep, and Dr. Disha, next check position of DLT. Okay, everyone is saying confirm the position of DLT.
Yeah, so that
Check
is
for the
what it is.
obstruction.
Yeah, so this is very clear that we can see the first step obviously is increase the FiO2. The second is to identify a treatable cause. And here we can clearly see that suddenly the airway pressure increase. And this is at the time of the hilar dissection. At the time of the hilar dissection, usually the surgeon manipulates and your tube will always, there may be a chance that the tube has migrated. And that is why it has resulted in increased airway pressure and decrease in the tidal volume. So if we do a bronchoscopy and we identify that the tube has been misplaced, it is going to, it can be taken care of and our saturation will improve. So that is the thing, identify the treatable cause. And if we find that the tube is misplaced, take care of it. Now we have another scenario here.
So the second scenario is 54 years male patient, obese, ASA2, carcinoma lung. So right VATS upper lobectomy has to be done. Left-sided DLT has been placed and patient is positioned in left lateral position. So after 20 minutes of one lung ventilation, so airway pressures are unchanged, vitals are stable, EtCO2 is 44 millimeters of mercury, but there is a gradual decrease in SpO2 to 88%. So how will you troubleshoot this? What is the reason and how will you manage? Please type your answers in the chat box. So Dr. Gauri has said to increase the PEEP. Dr. Archana is saying there is no, the pressures are unchanged. Okay. Increase FiO2. Position of DLT to be checked. Do arm maneuver, ARM maneuver. Any other answers? Suctioning, okay.
So yes, here again, the first thing is to increase the FiO2, but then again, we see this is an obese patient. So what are the things that we are going to do? One is, yes, increase the PEEP so that we improve, if there any basal collapse that is there. The second thing that we do is to apply CPAP to this non-ventilated operative lung. And the third thing that we can do is the use of ARMs. So here the tube, you may check the position of the tube, but we know that is not going to be the cause. Here very clearly, if I have said that it is an obese patient, then the maneuvers that are really going to help us are either PEEP to the dependent lung or CPAP to the non-dependent lung and use of an ARM maneuver. Now we have another scenario that is there.
So the next scenario is 70 years male patient, ASA2, has emphysema and left-sided VATS has to be performed with left DLT and there's a blood loss. So 1 hour of one lung ventilation is over and there is a decrease in SpO2 to 88% and there's no improvement with recruitment or PEEP and surgeon refuses CPAP. How will you go ahead? So Dr. Mukesh has told to suction the tube, Dr. Harita. So Dr. Anupriya is saying increase the FiO2 and replace blood. Dr. Archana is asking for transfusion and Dr. Pranav, hemodynamic stability should be done. Increase in FiO2, blood replacement and vasopressor. Increase in FiO2.
Yeah, so again here we see the cause is different. Here it is increase the FiO2 and because the blood loss has occurred, in fact use of recruitment and PEEP may further cause more hemodynamic instability and reduce the saturation. So what we have to do is maybe reduce the depth of anesthesia, replace blood or give him colloids if needed and start some kind of a vasopressors if required depending on the hemoglobin and the cardiac function of the patient. So with the help of these three scenarios, I just want to highlight that, we need to look into the cause of the desaturation or the hypoxemia that is happening intra-op, because it's not that, there is one thing that is going to be, in fact, at times it may be detrimental, like using PEEP or recruitment in this patient is going to be detrimental because it is going to cause more hemodynamic instability. Similarly, if, you have the tube position is fine, and if you're going to just try and manipulate the tube, it may cause more harm or more damage than it actually would. So look into the situation, look into the, the part of the surgery that is there, and look at all the parameters. And if we look at the troubleshooting tree, we know, if we take it step by step, we know we can identify the cause and correct the hypoxemia. And 90% of the time, if we do the right thing, we will be able to maintain oxygenation in all our patients. So I hope with this we have been able to go above the mountain and climb this thing of OLV, and we will be able to prevent ALI in our patients, which is a very dreaded complication. So I would like to thank you for this and listening to me and for this whole hour. And it's always better to prepare and prevent than to repair and prevent. Thank you.
Thank you so much, ma'am. You have simplified such a challenging topic. And we have with us Jayashree Sood, ma'am. Ma'am, please unmute yourself. I welcome you to ISA Online PG classes. Jayashree Sood, ma'am, is Director and Chairperson of in Institute of Anesthesiology, Pain and Perioperative Medicine in Sir Gangaram Hospital. Ma'am. And we also have with us our Honorable Past Secretary, Dr. Naveen Malhotra, sir. Sure, ma'am, we'll unmute you.
And I'd like to welcome everybody for the annual conference this year.
Yeah, yes, ma'am.
Yes.
Ma'am, you can unmute yourself, ma'am.
Thank you. Thanks, Monica. Thanks a lot, Sangeeta, for that so extensive and educative lecture, not only for the students, but the tips were very useful to us also who are practicing thoracic anesthesia. And definitely a very, very interesting lecture. And I like the way that you have pointed out these case scenarios as well, which have been discussed. And really, some of the students who have been answering them shows how they understood. It was a huge topic and so much to learn in it. So I'm sure they'll have to go through the YouTube again, the lecture tomorrow, so that they can actually grasp the whole thing. Sangeeta, thank you so much. That was absolutely excellent. And they
Can we take up the questions, ma'am?
Yeah, sure.
Yeah. Two of the delegates have asked how to do ARM.
Okay. So an alveolar recruitment maneuver, basically you have the expiratory valve, we close it, to depending if once the patient has to be stable and we know that he's adequately fluid loaded, we close the valve and slowly, hold the bag in, for at least 30 seconds in the inspired, you have to hold the bag and inflate the lungs and keep that sustained pressure for around 30 seconds. And that is going to help us to, we can see the improvement in the oxygenation as well as the, provided that there is no hemodynamic stability, the instability that is happening.
Thank you, ma'am. So Dr. Bhuvneshwar is asking, what should be the minimum acceptable intraoperative SpO2 level during one lung ventilation?
92%. And in some cases, even above 92% is what is acceptable in most of the patients.
Sure, ma'am. And another question is, what is the difference between recruitment maneuver and Valsalva maneuver on intubated patient?
Actually, the difference is that in a Valsalva, basically it is done to check the bleeding. And, so the surgeon asks you to perform the Valsalva maneuver. At that point of time, we are not really seeing whether, the oxygenation changes or not, or, and also we are not measuring as to, for how much time we are giving it and the pressure to which we are doing it. In an ARM, we actually see the pressure that we target and also the duration for which we are going to give it to the patient.
So Dr. Syed has asked why the left-sided DLT is preferred.
The left side is preferred one is because it is easy to place, because you don't have to align the slot. In the right side DLT, you have to align the slot against the right upper lobe to ensure that it is getting ventilated, and hence, and at times it is more time consuming, and also it is difficult to place because to align that slot towards the right upper lobe may not always be easy. And hence the left side tube is generally preferred because we don't have to align any slot. It is just we see the secondary carina and we can start with the surgery.
And Dr. Vishal has asked, what should be maximum PEEP during ARM?
Maximum PEEP during ARM.
Yes, ma'am.
Maximum PEEP, but I think during an ARM is basically the airway, to what airway pressure I think we can go. So I think the peak inspiratory pressure should not be above 40 centimeters of water, because we are closing the valve, and so the valve is closed at around 15 to 20 centimeters of water.
Dr. Lavith has asked how to give CPAP to non-ventilated lung.
I think CPAP to the non-ventilated lung. I just showed the, we can either you have a CPAP valve which can be applied, or you can even, if you don't have that CPAP valve, you can use a circuit, and with the help of the circuit, but then with the help of the circuit, you will not be able to measure what kind of CPAP we are doing. So, if you at times what we have done is, if the CPAP valve is not available, then you can connect the pediatric circuit, and with the help of that, just gently give small tidal volumes to that lung. Otherwise, it's always given with the help of the CPAP valve, which is attached through a separate oxygen source.
So Dr. Lalit has asked, in absence of pediatric fiber optic bronchoscope, what should be the method of lung isolation in pediatric patients?
The absence of pediatric bronchoscope, see, if the child, I said, if it's 8 years or 10 years and above and weighing more than 25 kgs, then we have the double lumen tube. If they are less than 8 years of age, or weight is less than 25 kg, then we can use bronchial blockers. The bronchial blockers, depending on if you have the pediatric size, they can be placed intraluminally through the endotracheal tube. Or if it's a really very small child, then they can also be placed coaxially. And sometimes in children, if you don't have the fiber optic, with the help of the rigid bronchoscope, you can just see, that where the blocker is going, which has been placed coaxially.
Sure. So Dr. Gauri has asked, can we use JR circuit for CPAP?
Yeah, that's what I said. We can use the pediatric circuit for giving CPAP.
Okay, so I think this is all. I will unmute everyone now, and everyone can ask questions to Sangeeta ma'am and Jashi Sood ma'am. If anyone has any.
Good evening, Dr. Sangeeta. This is Dr. Anshu S.S. Kotia. I would like to know that in how many percentage of cases in your career have you relocated and rather reinserted DLT, and after patient positioning, repositioning? What is the failure rate in your experience?
Ma'am, you can please unmute yourself. Yeah.
So patients in whom, you have small patients with a very small neck, and if they have too much of secretions, so maybe after, we have placed them in the lateral position, the tube may migrate, and sometimes there may be difficulty in these patients where, especially those who have bronchiectatic lungs, where there is too much of expectoration, or these patients who have a hydatid cyst and they are coughing out. So in those patients, you do have, at times it has happened that we have to again change them into the supine position and reposition our tube. But generally, all this is done before the surgery starts, because once the surgery starts, then it is difficult to do all this. So ideally, that is why this, we say that you have to use the fiber optic bronchoscopy even after, once in the supine position, and then after that, when we have placed the patient in the lateral position also.
Thank you, madam. But in one case of esophagus, in the GI surgeon was doing it in prone. Then he asked us to go for lateral. So it was a little bit difficult because the surgeon insisted just before the incision. So this was my question, that how to go about it.
How to,
How to, I mean, again and again, we'll do the fiber optic. We will confirm the position again.
yes.
My
Whenever there
question
is
is, if a surgeon says that, yes,
whenever there
madam.
is a change in position, we have to do a fiber optic bronchoscopy to confirm the position of the tube. That is there.
Okay,
That should
ma'am.
always be done.
Okay,
Yes.
ma'am.
Yeah.
Thank you so much.
Fiber optic is the must. Yeah.
Thank you, ma'am. Like auscultation should always be done in normal
Yeah.
care.
Yes.
Thank you, ma'am.
Thank you so much. Any other questions from our participants? We have with us Dr. Naveen Malhotra, sir.
So are these tubes, Dr. Sangeeta, are these tubes disposable? Totally?
Yes. Yeah, they are disposable
Or-
tubes.
And even blockers?
I didn't get it.
The blockers also you are disposing of? The blockers?
Yes, yeah, okay, it's a tricky question. They are disposable, but we at least use it twice or thrice, unless it's an infected case, because they're too
Yes, ma'am.
expensive.
Yes,
They're
ma'am.
too expensive.
This was my question.
The double lumen tubes we are disposing of, but the blockers we are reusing. Once, if the shape is maintained, and secondly, we've not used it in an infected patient.
Thank you so much. Thank you, ma'am.
Yeah.
We have more questions. Dr. Pranav has asked any other way to confirm the position of DLT except fiber.
Yes, these days the ultrasound is also being used to confirm the position. When we see, once the lung has collapsed, so we can see the seashore sign and all that. So if we have your ultrasound machine available, definitely you can use that also to confirm the tube position. But that will just tell you the lung is collapsed. It will not really tell you the, whether your bronchial cuff has been adequately inflated or not, and whether the cuff is herniating into the trachea, so those things you cannot make out. But yeah, if you don't have anything and you just want to ensure that your lung is collapsed, and secondly, yes, you can also, if you have a mobile X-ray machine under fluoroscopy, also you can check. But that is a very time-consuming procedure, because you'll have to ask for the, X-ray machine to come in, the fluoroscopy machine to come in, and then you check the position of the tube and the lung collapse.
Anybody practicing thoracic anesthesia, that is the least thing that they should have, is a fiber optic.
Yes.
Ma'am, Dr. Gauri is asking how much peak inspiratory pressure should be given during Valsalva?
Around not more than 20 centimeters, 15 to 20 centimeters.
And Dr. Naveen has asked plan of analgesia and role of total intravenous anesthesia.
Plan of analgesia in these patients is, if we are doing an open thoracotomy, then obviously epidural is the gold standard which is used. But if we are talking of minimally invasive procedures like VATS, then these days we have, for that you have the epidural or the paravertebral also available. But yes, nowadays with the VATS, we have the newer blocks. So the erector spiny block, or your SAP block, all of them, the serratus and deep serratus anterior plane blocks are also being used for VATS. And obviously it's a multimodal analgesia technique which we will use. So along with these blocks, we have to give them some kind of, anti-inflammatory medication like Vovaran or Crocin or paracetamol or something like that. But and Tiva is only used if you're doing an awake thoracic procedure. That is where it is preferred, like a dexmedetomidine infusion along with an epidural if you're doing an awake thoracic surgery. Other than that, Tiva is useful when we are doing surgery in the airway, for example, a tracheal bronchial repair, and you cannot ventilate the patient. So in those patients, Tiva is again beneficial.
Ma'am, slightly different question. Dr. Nikhil has asked how to conduct anesthesia for EBUS, endobronchial ultrasound.
Okay. See, most of the EBOS procedures are being done under MAC. That is, we don't have to really give them anything. What we are doing is we are nebulizing these patients with lignocaine and adrenaline, 2 or 3 rounds of that, so that the airway is desensitized when they pass the bronchoscope, and glycopyrrolate is given to them and an antiemetic along with that. And if some patients are really apprehensive, then we start them on a dexmedetomidine infusion. And generally they get done under local anesthesia with sedation is mostly required. Very rarely for an EBUS we need a general anesthesia technique.
Thank you so much, ma'am.
Sangeeta, I would just like to add, sometimes when we need to give GA, then probably with a ProSeal they can pass the bronchoscope through it and do the procedure.
Thank you so much, ma'am.
Thank you. Parul, you want to ask something?
No, sir, I just want to compliment ma'am that it was a beautiful and a very comprehensive lecture. Ma'am, could you just say something about the post-operative care, especially the physiotherapy part?
Okay, see, I think 90 to 95% of these patients have to be extubated on table. The indication of ventilating them should only be if, they came to us intubated, or there is major chest instability, or there was so much of hemodynamic instability that we, too much of blood fluid changes, fluid shifts occurred, and or if it's a myasthenic patient and we found that it is difficult to, extubate, some of them may be difficult to extubate. So ideally they should all be extubated, and physiotherapy is started immediately, maybe 2 to 4 hours after the surgery is done, and by next morning they are made to mobilized and out of bed. So because if we are providing good analgesia, then the next day they can be made to sit on the chair and mobilized, and after that spirometry starts simultaneously. And quite a few of them, if they need muscle strengthening, then treadmill or something, the physiotherapist usually starts that also, by the 2nd or 3rd day. They make them walking on the treadmill or the cycle to improve the muscle strength as well as continue with the spirometry.
Yeah. Thank you, ma'am. Thank you so much.
If you'll allow me, there is one more question in the chat box. They're not stopping.
Yeah.
So, can DLT be kept after surgery is completed, or we have to change it to single lumen ETT? Dr. Pranav is asking.
No, we have to change it to a single lumen tube. We do not continue with the DLT unless the reason for the DLT was, disruption of the tracheobronchial TAE, or we have to prevent some kind of, contamination. Then it's a different thing. Otherwise, we have to change it because the airway pressures are too high and suction and all is not really possible with a double lumen tube.
Dr. Jyoti is asking, what should be targeted predictive PFT values for patient who could tolerate one lung ventilation?
Predicted? See, that depends on the surgery the patient has to undergo. Whether he is for just a minor surgery, or it's for a lobectomy or for a pneumonectomy. So according to that, we are going to see what the, PFT for the patient is. So ideally for a pneumonectomy, the post-op predicted FEV1 should be more than 1.1 liter. And for a lobectomy, it has to be more than 1.5 liters.
Thank you, ma'am.
Thank you, Dr. Sangeeta Khanna, for an excellent and elaborative and exhaustive talk. I think you need a good big cup of coffee. And thank you for sharing your experience and knowledge with us on a very important and practical clinical topic. Yes, not only in the thoracic anesthesia, but in different aspects of anesthesia and critical care. And thank you, Madam Jashood, Madam, for gracing the occasion and chairing the session. It has been a pleasure to have both of you with us today evening. And it was, as the compliments are going, it was a very, very nice class, and it shall be having lots of views on YouTube also. So thank you to both of you, and thank you, Monica, for nicely coordinating the session. We shall meet next Monday, same time, for another important class on how to restrain an agitated patient in ICU, ethical and legal dilemmas by Dr. Pradeep Bhatia of AIIMS Jaipur. Thank you all.
Thank you so much, Naveen. Thank you.
Thank you, ma'am.
Sangeeta. Thank you, Monica. Bye-bye.